Hello everyone. So today we are going to cover one of the objectives from MCC website, that is diabetes. So for MCCQE1, where do you have to study diabetes from? So you can start studying from Toronto notes as well. But today I'm going to cover one of the this objective from one of the Canadian guidelines. So stay with me. So this is one of the diabetes objective that was updated in March 2023. You can see the date up there. So diabetes is common multi-system organ disease, and so what do we have to cover? We have to cover type 1 diabetes, type 2, and then gestational insulin deficiency and other specific type of diabetes. So there is a very good chart in Toronto notes that I can show you right now. So that chart is really good to cover these different types of diabetes. So here you go. The table 5 etiology is the one that shows that covers that particular part of the objective. So type 1 is an autoimmune. We all know there's a beta cell destruction, and there's insulin, absolute insulin deficiency. That's why we give insulin as a treatment of type 1 diabetes. Type 2 diabetes is there is insulin, but it's not enough, or even if there is enough, it's not effectively working. That means there is resistance to insulin. Then other specific type has a genetic, where it is known as maturity onset diabetes of young. There's beta cell destruction. And then there is exocrine type of diabetes because of pancreatitis, neurofibromatosis, pancreatitis, neoplasia, cystic fibrosis, hemochromatosis, which is also known as bronze diabetes. And then endocrinopathies like acromegaly, Cushing syndrome, glucagonoma, pheochromocytoma, hyperthyroidism. Drug-induced diabetes is caused by glucocorticoids, thyroid hormone, beta-adrenergic thiazide, phenytoin antipsychotic. Infections are cytomegalovirus, rubella, and Coxsackie virus. Genetic syndromes are Down syndrome, Klinefelters, and Turner syndrome. And then there's gestational diabetes that would be covered in obstetrics. And then on the right side, you see HbA1c target for the patients with diabetes is less, it should be less than 7. Plasma glucose should be 4 to 7 millimoles, and 2 hour postprandial should be 5 to 10, and lipids should be less than 2. LDL should be less than 2 or less or 50%, or blood pressure should be 130, less than 130 by 80. So these are the basic things that you need to remember. So even if you go through the charts or tables of Toronto notes, that would be enough. But I've seen a new guideline. So all these things are covered from, you see, diagnostic criteria as per Canadian 2018 clinical practice guidelines. So why not we read the guidelines and then we come back to here, right? So I'm going to open these guidelines here. And before opening the guidelines, just review the objectives, that what do they want to know. They want you to know the history, interpret medical history, clinical finding, and results of investigation, identifying risk factors, diagnosis, secondary causes and complications, and also the management plan. So education and counseling on the management part, lifestyle modification, risk factors management, intensive glycemic control and pharmacological therapies, and prevention and management of hypoglycemia, DKA, and hyperosmolar non-ketotic coma. And then prevention and management of the complications, micro and macrovascular complications. So let's go ahead and start with the guidelines. So this is 2018 clinical practice guidelines, quick reference guide, and this was published in 2018. These are the latest guidelines for diabetes in Canada. So screening and diagnosis, how do we start? So these are the risk factors for type 2 diabetes that we need to assess annually. Whenever the patient is coming in office for periodic health check, we need to make sure that we are checking if the patient has a family history of diabetes in the family. Is there any first degree relative with type 2 diabetes? We have to check the high risk population. Who are the high risk population? Asians are, Europeans are high risk population for diabetes. But high risk are non-white, low socioeconomic status. These are high risk population. And history of GDM in a patient or pre-diabetes in a patient is a risk factor for development of diabetes. Cardiovascular risk factors, obesity, presence of end organ damage associated with diabetes, other conditions and medications associated with diabetes. So these are some of the risk factors. Medications, we have seen corticosteroids, phenytoin, thiazide diuretics, beta adrenergic agonist, and antipsychotics like olanzapines are the medication that may have the patient to have diabetes, right? So who to screen? Now, if there is no risk factors, the patient is less than 40 years of age, low moderate risk, no screening is indicated. But if the patient is more than 40 years of age, now patient has reached 40 years of age, you need to, patient is in the office for periodic health check, make sure that you write HbA1c and fasting glucose test for that patient, and just see if the reading is negative for both of them, that's okay. The patient will be screened in next 3 years. That is, if the patient has come in today, let's see 2024, the next screening for diabetes would be 3 years after, that is in 2027. So 33% of chances of developing type 2 diabetes within 10 years. Okay, so patient is more than 40 or a high risk patient, then there is 33% of developing type 2 within 10 years. So you'll screen the patient in next 3 years. Then there is a presence of risk factors. Let's say a patient is a obese patient, has a family history of diabetes, 50% of chance of developing type 2 diabetes within 10 years. So the risk has doubled now. So what you will do, you will do screening in next 6 to 12 months for high risk patient. And who are high risk? We have already mentioned patient with family history, obesity, a high risk population like low socioeconomic, non-white people, history of pre-diabetes or GDM are all high risk patients. Okay, so this is how you go about the screening. Number one is age, number two is the risk factor. Age is less than 40, no need to screen. If age is more than 40, screen the patient now, and then if there is low risk, in next 3 years. If the patient is high risk, then you need to start screening irrespective of the age, and you need to screen the patient every 6 to 12 months if the patient has any high risk. Okay, and then let's say how to screen. Now what to do, there are two different tests. One is HbA1c and the other one is fasting blood glucose. For HbA1c, HbA1c of 6 to 6.4, patient is pre-diabetic. If it's going more than 6.5, patient is diabetic now. For fasting plasma glucose, it should be 6.1 to 6.9, patient is having impaired fasting glucose, that is pre-diabetic. If it is more than 7, then the patient is diabetic. And for how long the patient should be fasting for 8 hours. Okay, so these are the things. Now if the patient is asymptomatic, let's say HbA1c and fasting blood glucose both come out positive, that means the patient has diabetes. So but the patient is not symptomatic, what we will do, we will repeat the test to see if it's accurate. If it again come positive, that means patient has diabetes and he's not symptomatic, right? But now let's see, if both are available and they are both positive, that means the patient is symptomatic, that means patient has diabetes, no need to repeat that. But if both are done but one is positive and one is negative, that means one test has reading more than, let's say, 6.5, HbA1c is positive but fasting is okay, then we need to also repeat the test. Okay, and then if both HbA1c and fasting are available and each has diabetes range, then the test can say, let's say, it's confirmed. Okay, so if symptoms of overt hyperglycemia are present, diagnosis of diabetes can be determined with one test, HbA1c, fasting glucose, or random plasma glucose, or 2 hour post prandial glucose in diabetes range. So even if the patient is symptomatic, any one test can confirm that yes, the patient has diabetes. Okay, uh, all right. And also there is a calculator, can risk calculator, to assess for the risk of the patient. So how would you see the risk? Like the one that we mentioned in the screening, the patient is high risk, low risk, or moderate risk. So they're saying use a validated risk calculator, that is can risk. There's a calculator, can risk. Let's just have a look on that one as well. Okay, here you go, can risk. So can risk is a calculator for uh, here is a calculator. Just have a look on the components of the calculator. uh, so it is used by a CanRisk as a calculator to use for patient to discuss breast and ovarian cancer risk factor for the patient. Let's see a simpler form of it. So here you go, we so this is the score. So if the point is between 32 0 to 32 low risk, 33 to 42 is high risk, and then 43 to 87 is very high risk. And these are the questionnaire, right? So as you get older, you get the risk of developing diabetes. Select the age group. So 45 to 57 points, male or female. Female has 6 points. BMI is one of the component. Body shape like inches. So you can do it in a clinical setup. And then the blood pressure, blood sugars, pregnancy related factors, types of. So quickly just have a look on the factors. Have your father been diagnosed with diabetes, brother or sister been diagnosed with diabetes, children ever been diagnosed with diabetes, ethnicity, let's say South Asians like in East Indians, Pakistani, Sri Lankans have risk of like points of 11 points, and then East Asians like Chinese, Vietnamese has 10 points. Black Africans, Africo-Caribbeans has 5 points, Aboriginal have 3 points, white Caucasians have 0 points. And level of education. So the more educated the patient is, the less points are. Let's say university has 0 points, colleges have 0 points, and that's how it is. And then this is the chart for seeing the recommendations. Okay, so for low risk 0 to 30, Canadian Task Force recommend not routinely screening for type 2 diabetes. 33 to 42 recommend every 3 to 5 years, and 43 to 85, that's what we read. So we need to recommend annual screening, or let's say 6 months to 12 years. So these are the website specific that you need to look into before you dig into the books, because these are the most accurate ones. Okay, so we have covered the CanRisk calculator, we have studied the screening guidelines, and then what do we have to use for screening, right? What test we are using. Now target is HbA1c should be less than 6.5. Adult with type 2 diabetes to reduce the risk of cardiovascular risk of CKD and retinopathy if at low risk of hypoglycemia. So if the patient is at low risk for hypoglycemia and there is a steric, let's read that based on the class of anti-hyperglycemic medication utilized and the person's characteristic. So we need to see if the patient is at low risk for developing hypoglycemia, we need to keep the HbA1c of less than 6.5. But if most adult with type 1 and type 2 diabetes, it should be less than 7. And 7.1 to 8.5 for those with functionally dependent, recurrence risk of hypoglycemia and hypoglycemic unawareness, limited life expectancy, frail elderly or with dementia. So for old age population, they're keeping the HbA1c range of 7.1 to 8.5. Let's say a patient who's 70-year-old has an HbA1c of 8, or let's say 8.5, that is good for him. We are not sure, we're not supposed to emphasize that start skipping the meals, or start having a low sugar diet, or no, because the patient can end up having hypoglycemic episode, and he may not be even aware of the hypoglycemic event. So it's better not to recommend them to have a strict control of their glucose, right? So 7.1 to 8.5 is okay for elderly population or patient with hypoglycemic agents, and then 7 is generally good for type 1 and type 2 diabetes. And generally, if we want to prevent the occurrence of microvascular complication, then we can recommend, let's say, go beyond 6.5, less than 6.5. Avoid higher HbA1c to minimize the risk of symptomatic hyperglycemia and acute or chronic complications, right? So that's how the HbA1c target should be. So blood glucose lowering therapies. At the diagnosis of type 2, start healthy behaviors, nutritional therapies, weight management, physical activities, and metformin. So how do we have to manage type 2 diabetes? We have to start with behavioral modification. That is one of the favorite questions for QE1, that they want to know what are you going to start the patient on. You're going to start the patient on behavioral interventions, that is nutritional therapy, weight management, physical activity, and plus minus metformin. So you need to start with nutritional therapy, nutrition, diet, weight management, and physical activity. Nutrition, weight management, and physical activity, three most important things that are supposed to be covered in behavior intervention: nutrition, weight management, and physical activity. Okay, plus minus metformin. So let's say HbA1c less than 1.5% above the target. Okay, if not at glycemic target within 3 months, start or increase the metformin. So what happens is, let's say a patient has an HbA1c let's say of 6.5 or 6.6. You'll start with behavioral modification, and you may give the patient a timeline of 3 months, and then you repeat the HbA1c in 3 months. If the HbA1c is still the same or is going beyond the range, that is 6.7, 6.8, you need to start the patient on metformin, but give the patient the 3 months time, and then you may start or increase metformin. If not at target, now start anti-hyperglycemic agents with demonstrable cardiovascular benefit. Now if, for example, you've started the patient on metformin, even then the patient is not on a good control, you would now start the patient on the medications with good cardiovascular benefit, that is empagliflozin grade A, level 1A, liraglutide, or canagliflozin. Okay, so empagliflozin is grade A, that is good for heart. Liraglutide is also another one that is recommended. These are GLP 1. Okay, and yes, GLP-1 agonist, liraglutide and semaglutide, these are GLP-1 agonist. So these are recommended for patients with cardiovascular risk or cardiovascular diseases. Okay, and also empagliflozin is let's see, as it's an DP no, it's an SGLT2 inhibitor. So that is even recommended for a patient with cardiovascular diseases, because it has a significant benefit on the cardiovascular health. So if the patient has, let's say, not on a on a good glycemic target even now, what are we going to do? Add additional anti-hyperglycemic agent best suited to individual based on the following: clinical consideration, avoidance of hypoglycemia, weight gain, with adequate glycemic efficacy. So we need to give DPP-4 inhibitors or GLP-1 receptor agonists or SGLT2 inhibitors. So we'll look into like what exactly the medications they belong, what medications they have in their classifications. But for now, just have a clear understanding of like if the patient has hypoglycemia risk, we need to avoid that risk, right? If the patient has a complaint of weight gain, so we need to make the patient lose weight and with adequate glycemic control. So these are the drugs that are recommended for weight gain, avoiding hypoglycemia and having a good control. These are DPP-4 inhibitors, GLP-1 receptor agonists, and SGLT2. So let me make you revise what medications they belong to. DPP-4 are so let's start with GLP-1. So GLP-1 receptor agonists are liraglutide. Superiority in people with type 2 diabetes with clinical cardiovascular exenatide, liraglutide. And the risk of hypoglycemia is rare, and weight gain, it causes weight gain. Relative HbA1c lowering is good. What are the side effects? Side effects are GI side effects: gallstone, contraindicated with personal or family history of medullary thyroid cancer, meant to and require subcutaneous injection. So this is the information that is exceptional. So you would get to know from these guidelines. This is not something that you would find everywhere. You may find it in Toronto notes, but this is where if you start learning this way, this is going to be helpful in future as well. Okay, so GLP-1 receptor agonists are liraglutide, exenatide. These are the drugs. Now what are the side effects? Okay, side effects are gallstones, contraindicated with personal or family history. Let's say they may give you that a patient has a family history of medullary thyroid cancer or MEN2. You would not give GLP-1 receptor agonist in those patients. Liraglutide, semaglutide, and exenatide, these are the drugs. Let's say semaglutide is Ozempic, the very famous one. So patient has a gallstone, do not give them Ozempic. Patient has a family history of medullary thyroid cancer, patient has a family history of MEN2 cancer, do not give Ozempic. GI side effect is one of those very common ones, and they require subcutaneous injections. So Ozempic is available in the form of injection, but the cost is very high. You see, there are 4 signs of the cost, so that means it is very expensive. Side effects are gallstones and MEN2, contraindicated MEN2 and medullary thyroid, and then it lowers the HbA1c with a very good number, like it's literally 2 to 3 downward arrows. That means really good for lowering HbA1c, and then it also reduction or weight reduction is really good with a GLP-1 agonist. GLP-1 receptor agonist, these are liraglutide, semaglutide, and exenatide. You can remember with Ozempic, that's the best example. Ozempic is GLP-1 receptor agonist. Weight loss is good. HbA1c lowering is very good. Contraindication is MEN2 and medullary thyroid, even in the patient or even in the family history, right? And requires subcutaneous injection, and one of the side effects is gallstone disease, right? But it's very expensive. Now coming to SGLT2 inhibitors. So we were giving it in the patient with the avoidance of hypoglycemia, weight gain, and good glycemic control. We do give GLP-1. Now coming to SGLT2 inhibitor. SGLT2 are canagliflozin, empagliflozin, superiority in patient with type 2 diabetes with clinical cardiovascular disease. So the top 2 right now, GLP-1 agonist, SGLT2 inhibitors, we are all giving it in patients with the diabetes and cardiovascular disease, right? Weight gain is good with SGLT2 inhibitors. HbA1c is going down, but genital infection is a side effect. UTI, hypotension, those related changes in LDL-C, caution with renal functions, loop diuretics in elderly. Dapagliflozin is not used if bladder cancer. Rare diabetic ketoacidosis may occur with no hyperglycemia, increased risk of fractures, amputation, and canagliflozin. Reduce progression to nephropathy and congestive heart failure, hospitalization with empagliflozin and canagliflozin in persons with clinical cardiovascular disease. So you see, reduce progression of nephropathy and congestive heart failure with empagliflozin and canagliflozin in person with cardiovascular disease. So this is really good for patients with cardiovascular disease. Even with nephropathy and heart failure patients, you can give SGLT2 inhibitors, which is canagliflozin, empagliflozin, are very famous drugs these days. But the side effects is genital infection, UTI, hypotension, dose-related changes in LDL-C. We have to be very careful in patients with renal dysfunction, loop diuretics, and in elderly. Okay, dapagliflozin not used in bladder cancer. So one of the unique features of dapagliflozin is that we need not to give it in patients with bladder cancer, rare diabetic ketoacidosis, increased risk of fractures, amputation with canagliflozin. So dapagliflozin not indicated for bladder cancer. Canagliflozin may increase the risk of fractures, right? And other than that, UTI, hypotension, genital infections, and cost is also expensive, but less expensive than GLP-1 receptor agonist, that is Ozempic, liraglutide, semaglutide. But EMPA, dapagliflozin, these are all SGLT2 inhibitors, which are a little bit more expensive, but have good efficacy with lowering HbA1c, decreasing weight, but has the side effects of UTI, genital infections. Dapagliflozin not to be given in patients with bladder cancer. Canagliflozin may increase the risk of fractures, but a very good effect on nephropathy and patient with congestive heart failure, right? Now, DPP-4 inhibitors are saxagliptin, allogliptin, and sitagliptin. So hypoglycemia is rare. You see, it's rare with top three medications. Now, DPP-4 inhibitors has neutral weight loss, but its lower HbA1c is good. Saxagliptin in heart failure, we have to be really careful and may cause joint pain, and it's also very expensive. So we don't have really lots of side effects with this medication, but saxagliptin we have to be careful in heart failure patient. And weight loss is not really associated with this medication like saxagliptin, DPP-4 inhibitor. So weight loss is really good in medications like GLP-1 agonists and SGLT2 inhibitors, right? Now coming to insulin, we have neutral deglutide, non-inferior to glargine. So you see, insulin is associated with hypoglycemia. Yes, weight gain is more, like patient will gain more weight, and it will lower HbA1c. No dose ceiling, flexible regimes require subcutaneous injection, and insulin is very expensive. Okay, so insulin is expensive. It does cause low HbA1c, but it also makes the patient gain weight, and also it is associated with hypoglycemia. So two most important things that you need to remember for insulin is the patient may have weight gain, and the patient may have hypoglycemia. So two more important thing for insulin. Okay, now thiazolidine are neutrals. They do not, rare hypoglycemia is rare. And now weight gain is more with thiazolidine and it causes lowering HbA1c effect. Thiazolidine are not really good for congestive heart failure, edema, fractures, bladder cancer, pioglitazones, cardiovascular controversies, rosiglitazone. 6 to 12 weeks required for maximum effect. So not the best medication, I would say. Has a low HbA1c lowering effect, but we have to be very careful with patients who are in congestive heart failure. It's not recommended. Even it may cause fractures, edema, bladder cancers. Now, alpha glucosidase inhibitors, acarbose, it causes low HbA1c. GI side effects are common, require 3 times daily dosing, so it's not the best one, I would say. Secretagogues are meglitinide and sulfonylureas. They may cause hypoglycemia. You see, hypoglycemia, yes, with meglitinides and sulfonylureas, and it is increasing the weight, right, and lowering the HbA1c. So with meglitinide, more rapid blood glucose lowering response, reduce postprandial glycemia with meglitinide, but usually requires 3 to 4 times daily dosing. And glicazide and glimepiride associated with less hypoglycemic than glyburide, poor durability. So patients I have seen may have hypoglycemia with the sulfonylureas because they causes secretion of the insulin. So glicazide and glimepiride associated with less hypoglycemia than glyburide. Glyburide is one of the secretagogue sulfonylureas that causes hypoglycemia. Meglitinide also lowers the blood glucose but requires multiple dosing, right? Even with the carbos like alpha glucosidase inhibitors, they require like 3 times daily dosing. Weight loss, orlistat may cause weight loss, and GI side effects are associated with orlistat, and it also requires 3 times daily dosing, right? So if not glycemic target, then add another anti-hyperglycemic agent from a different class and intensify insulin regime. So let's say we have given the patient metformin and another drug. The patient has not achieved the target, so what we can do is we can increase the dosage of the insulin, or we can add on insulin, or we may add on another drug depending on the patient's condition. Make timely adjustment to attain target HbA1c within 3 to 6 months. So our target is to maintain HbA1c in 3 to 6 months, right? Okay, now we need to remember the side effects of each of the medication. Okay, so the top three ones right now are GLP-1 agonist, and SGLT2 inhibitors, and DPP4 inhibitors, right? DPP4 are saxagliptin, sitagliptin, and SGLT2 are empagliflozin, and canagliflozin, and GLP-1s are liraglutide and exenatide, right? So now coming back to the table that we read here, so glucose lowering therapy for type 2 diabetes. If HbA1c target is more than 1.5 with the target, we have to start. If it's less than the target, let's say the target is less than 6.5, right? But if it's 6.3, 6.4, lifestyle modification with metformin plus minus, right? If after 3 months you see the HbA1c has static, so you continue on the same drug. But if the HbA1c is increasing, if now it is more than 1.5 times percent of the above, that is, if it's let's say 7.5, now we have to start on metformin and consider second concurrent antihyperglycemic agent with metformin, right? Clinical cardiovascular disease, if yes or no. If yes, we need to add empagliflozin, liraglutide, or canagliflozin. Empa or liraglutide, right? Liraglutide is GLP-1 agonist, and empagliflozin is SGLT2 inhibitor. So if the patient has cardiovascular disease, we need to consider empagliflozin or liraglutide with metformin, right? And if no, then we can start any of the drugs, right? Okay. Now, symptomatic hyperglycemia and metabolic decompensation. For if the patient has symptomatic hyperglycemia with metabolic decompensation, start on insulin with metformin, and then we can add on the therapies accordingly, right? So that's how you do. So we need to make sure that within 3 to 6 months we make the patient within the target come. We make the patient come within the target range of HbA1c, right? So these are the things, and other considerations are reduced eGFR, albuminuria, cardiovascular risk factors, degree of hyperglycemia, comorbidities, congestive hepatic disease, planning pregnancy, cost and coverage, patient preferences. So you need to keep in mind the renal functions, cardiovascular risk factors, hyperglycemia, hypoglycemia, pregnancy, heart failure, liver disease, cost, and patient preferences, right? So starting with DPP4 inhibitors, GLP-1s or SGLT2s, right? GLP-1s are liraglutide, exenatide, semaglutide, and then SGLT2 are empagliflozin, dapagliflozin, and then DPP4 are saxagliptin and sitagliptin, right? So these are the medications. Now, which cardiovascular protection medications are indicated for my patient? Does the patient have cardiovascular disease? If yes, cardiac ischemia, silent or overt, peripheral arterial disease, cardiovascular carotid disease. What do you need to do? You need to start the patient on statin, number one. Now, you need to also give ACE or ARBs. ACE or ARBs, not together, right? Because together they may cause hypokalemia, and that's not good, right? So either one of them. And you have to make sure the patient is on aspirin. Patient is diabetic with cardiovascular diseases. Three medications you need to remember: statins, ACE or ARBs, and aspirin. And if the patient is not at glycemic control, so we need to add. The patient is not on glycemic control. Now you need to see what you can do. You would add liraglutide, that is GLP-1 agonist, that we remember, right? Empagliflozin, that is and or canagliflozin, that is SGLT2 inhibitors, only for patients with type 2 diabetes. So with cardiovascular disease, the patient is on cardiovascular disease and type 2 diabetes, you would give patient liraglutide, empagliflozin, or canagliflozin, right? Now, if the patient is does the patient if does the patient doesn't have cardiovascular, does the patient have microvascular disease like retinopathy, kidney disease, neuropathy? And by kidney disease, albumin creatinine ratio of more than 2, so we need to start the patient on statin, ACE inhibitors, and ARBs, right? And if no, is the patient age more than 55 with additional cardiovascular risk factor, even then we need to start the patient on ACE inhibitors, ARBs, or and with statin, right? So we need to see if the patient has cardiovascular diseases. Yes, add these things, right? The three things: statin, ACE inhibitors, aspirin. Patient has good glycemic control. No, then you need to start on liraglutide, empagliflozin, or canagliflozin, right? And then the patient has microvascular complications, statin or ACE inhibitors. And is the patient more than 55 with additional cardiovascular, start statin and ACE inhibitors. If the patient is more than 40, more than 30 with 15 years of diabetes, warranted for statin therapy based on the Canadian cardiovascular, then we need to start statin. So these are the risks associated that we need to see, that if the patient has type 2 diabetes with, along with, let's say, age more than 40, age more than 30 with 15 years of diabetes, or patient has cardiovascular risk factors, microvasculopathy, then we need to start the patient on statin, right? So those adjustment, additional lipid warranted lipid target is LDL less than 2 millimole. ACE inhibitor should be given at a dose that demonstrates vascular protection. Prendopril 8 milligram once daily. Ramipril 10 milligram once daily. Telmisartan 80 milligram once daily. So doses are adjusted accordingly. Aspirin should not routinely be used for primary prevention of cardiovascular disease in patient with diabetes. Aspirin should be used for secondary prevention. Consider clopidogrel if aspirin is intolerant. So aspirin is not something that we would right away give to the patient who's not even like let's say a patient is pre-diabetic, we would not give aspirin right away. Let's say a patient is diabetic now, has cardiovascular disease, start on aspirin. Canagliflozin avoid in patients with lower extremity amputations. Prior lower extremity amputation. Why? Because canagliflozin, we have read here, you see here it's written that there is increased risk of fractures or amputations with canagliflozin. So you are supposed to be very very careful with patients who are on already had a prior amputations and now you're giving in canagliflozin. No, that's not recommended. You may replace it with empagliflozin or any other type of SGLT2 inhibitors. Right now, keeping patients safe when they are at risk of hypoglycemia. Patients using insulin or insulin secretogogues like meglitide, glyburide, gliclazide, rapaglinide, recognize, ask at each event, each visit, assess, ask, assess, including fear, intentional avoidance of low, screen for hypoglycemia unawareness, ask, assess, and screen for hypoglycemia awareness. Act, educate on appropriate treatment, and need to have fast acting sugar treatment available at all times. So first of all, you need to see the patient is in clinic, he's on glyburide or gliclazide or rapaglinide, right? Three top drugs that they have mentioned here are insulin and secretagogues. Secretagogues are glyburide, gliclazide, and rapaglinide. So you need to recognize, ask, assess, and screen the patient if they are aware of the side effects, right? And then uh, act, treat them, educate them that in case it happens, this is what you have to do, right? Prevent, consider medication with lower risk of, even if there is another option available for anti-hypoglycemia for the patient that should have like lower risk of hypoglycemia, go ahead with that. Advise the patient to start on that medication. Discuss possible causes and how to avoid future hypoglycemia, and let the patient know like what do they need to do. So ask, assess, and screen, and then act and prevent. Prevention by considering the medication of lower risk and discuss the possible cause. Reduce the driving risk. Very important. Educate the patient to drive safely with diabetes. Prepare. Keep fast acting sugars within the reach and other snacks nearby. Be aware of blood glucose before driving every 4 hours during long drive. If blood glucose lower 4 millimole, treat. Stop drive and treat if any symptoms appear. After treating a low, wait until blood glucose is above 5 millimole to start driving again. Note, brain function may not be fully restored until 40 minutes after hypoglycemia is restored. So you need to educate the patient on these things, that even if you're driving, you need to make sure that you monitor your blood glucose before you drive. And if you're going for a long drive, make sure to monitor your blood glucose every 4 hourly. If it's going less than 4 millimole, you need to stop. You need to treat yourself with 15 grams of sugar, let's say 3 packets of sugars, or 15 grams of sugar, or 3/4 cup of orange juice. You need to have it right away, and then wait for some time, recheck your blood glucose level. If it's going above 5, then you may resume driving. Otherwise, you need to wait and just monitor your sugars every 5 minutes, right? Brain functions may take 40 minutes to restore. If the patient is unaware of the symptoms of hypoglycemia, he or she must check the blood glucose before driving and every 2 hours while driving, or wear a real-time continuous glucose monitoring. So continuous CGM, right? So continuous glucose monitoring, every 2 hours monitoring, and patient should be educated on the symptoms of hypoglycemia. Keeping patients safe when they are at risk of dehydration. So the first thing was to tell the patient about hypoglycemia. First thing is medication adjustment, then educating the patient about hypoglycemia, educating the patient about driving, and now the second part is first was hypoglycemia, second was driving associated with hypoglycemia. Now keeping patients safe when they are at risk of dehydration, vomiting, and diarrhea. Rehydrate appropriately. Water, broth, diet, soft diet, sugar free, cool, aid, diet, gel, o. Avoid caffeinated beverages, hold said men's med. So this is a very important mnemonic you need to remember. These are the medication that you need to stop when the patient is ill, dehydrated, or is not drinking enough water. So we need to stop these drugs. These are sulfonylurea, secretagogues for for S. For A is ACE inhibitor, D for diuretics or direct renal inhibitors, M for metformin, A for ARBs, N for non-steroidal anti-inflammatory drugs, S for SGLT2 inhibitors. Okay, so we need to stop these drugs once the patient is stable, is eating normally, so we can restart these drugs. Sadmans is the mnemonic. Special consideration for women with type 1 and type 2 diabetes. Pregnancy should be planned with the following steps taken prior to conception. HbA1c is 7 or less, but strive for less than 6.5. Ensure contraception until personalized targets. So you need to make sure the patient is on contraception until the personalized target are achieved. So to become pregnant, a type 2 diabetic patient should have a target HbA1c of less than 7 or should strive for less than 6.5, right? In the meantime, she needs to be on a contraception, right? Stop non-insulin antihyperglycemic agent except metformin or glyburide. Non-insulin antihyperglycemic agents should be stopped. Statins should be stopped. ACE inhibitors, ARBs prior to pregnancy, but if avert nephropathy exists, continue until detection of pregnancy. So these are the drugs that are supposed to be stopped. Non-insulin antihyperglycemic agents like metformin, except metformin or glyburide. So in non-insulin, we mean to say SGLT2, GLP-1, DPP-4, acarbose, right? These are all supposed to be stopped, number one. And number two, statins are supposed to be stopped. ACE and ARB is supposed to be stopped. But if patient is still not pregnant, she's planning to become pregnant, she can continue until she becomes pregnant. Once she becomes pregnant, she needs to stop ACE and ARBs prior to the pregnancy, right? We need to start her on folic acid 1 milligrams per day for 3 months prior to conception. Insulin if the target HbA1c is not achieved, on metformin or glyburide type 2. Other antihypertensive agents safe for pregnancy, labetalol, nifedipine if hypertension controls is needed. So how to manage the patient who is now pregnant, and now what you need to do? We are stopping statins, right? We need not to give any replacement. First thing for pregnancy is 1 milligram folic acid 3 months prior to conception. Folic acid 1 milligram per day for 3 months prior to conception, number one. Insulin should be started to the patient who's type 2 diabetic, right? Who's diabetic actually. And the medication wise, we may give metformin or glyburide depending on the need, right? And for blood pressure control, let's say a patient is hypertensive, we can give labetalol, we can give nifedipine, calcium channel blocker or beta blocker, but we are not supposed to give ACE or ARBs, right? So screen for complications, eye appointments, screen creatinine, urine albumin creatinine ratio, and blood pressure. Aim for healthy BMI, ensure appropriate vaccinations have occurred, refer to diabetes clinic. So these are the things: eye appointment, creatinine, albumin creatinine ratio, blood pressure control, diabetes clinic, BMI should be accurate, vaccination should be proper, right? 3 quick questions to help your patients meet their goals. For patients who are not making expected progress, try asking these questions to identify a path forward. How important is it for you to insert self-management goal, like whatever the goal is? Is it low, medium, or high? Goals examples are increase level of physical activity, reduce weight. How important is for you to reduce weight? If important, motivation is rated low, ask what is, what would you need to happen for importance to go up. A high level of importance will indicate the patient is ready for a change. So you ask the patient how important it is for them, how confident they on their ability. If they are on low, then explore what needs to happen to increase their confidence. Usually this has to do with improving knowledge, skills, or resources and support. A high level of confidence indicates the person is ready for a change. Can we start a specific goal for you to try before the next time we meet? What steps will you take to achieve it? Encourage smart goals, specific, measurable, achievable, realistic, and timely goals, right? So we need to ask these 3 questions to help patient meet the goals. What is how it is important for you, how confident are you, and what are the specific goals that we are setting for you until the next meetup, right? Individual goal setting: eat healthier, see a dietitian to help develop a healthy eating plan. Be more active, increasing physical activity with a goal of getting to 150 minutes aerobic activity per week. Resistance exercise, 2 to 3 sessions per week. Choose physical activity that meets the preferences and needs. Lose weight, use strategies like to lose 5 to 10% of the initial body weight. Take medications regularly. Taking medications will help you improve symptoms and control of your life. Consider using pill box or setting a time. Avoid hypoglycemia, recognize the signs of hypoglycemia, check blood glucose, establish a routine and act accordingly, check feed, do a safe daily self-check and follow up with a healthcare provider if anything is abnormal. Manage stress, screen for distress, depressive and anxious symptoms by interviewing a standardized PHQ-9 questionnaire, and reduce and stop smoking. Identify barriers or quitting and develop a plan to address each of these. Now, ABCDs of the diabetes are: A for HbA1c target of less than 7 or less than 6.5 to reduce a cardiovascular disease or retinopathy. If on insulin or insulin secretagogues, assess for hypoglycemia and ensure driving safety. B for blood pressure less than 130 by 80. If known on treatment, assess for risk of falls. Cholesterol less than 2 millimoles or more than 50% reduction from baseline. Drugs for risk reduction: ACE inhibitors. Cardiovascular disease, age more than 55 with risk factors or diabetes complications. Statins for more than 40. Type 2 diabetes or diabetes complication: aspirin. SGLT2 or GLP-1 with demonstrated cardiovascular benefit if type 2 diabetes with cardiovascular disease and HbA1c not at target. Exercise goals and eating healthy: 150 minutes of moderate vigorous aerobic exercise per week, and resistance exercises 2 to 3 times per week. Follow healthy dietary pattern, that is Mediterranean diet or low glycemic index. Mediterranean diet and low glycemic index. Screen for complications: cardiac like ECG every 3 to 5 years if age more than 40, and diabetes complication: foot monofilament vibratory yearly or more if abnormal. Kidney testing: EGFR, albumin, creatinine yearly or more if abnormal. Retinopathy type 1 annually and type 2 every 1 to 2 years. So these are the screening guidelines. ECG we have to do every 3 to 5 years if patient is more than 40. Monofilament annually. Kidney test annually, right? Uh, and retinopathy is also annually. For type 1 and for type 2 is 1 to 2 years. Smoking is if a smoker asks permission to advise, arrange therapy and provide support. Self-management, stress and other barriers: set personalized goal, individualized goal setting panel, assess for stress, mental health and financial or other concerns that might be barriers to achieve the goal. So that's about it. This particular table is very important, and by important I mean to say that you will frequently see questions related to exercise, healthy eating, screening, and even the drugs like aspirin, statins you need to know. So that's about it. I'll just quickly go and see risk factor diagnosis, secondary causes, complications. So we have mostly covered this objective right now here, and yeah, so you can also see the guidelines. Let's see this PDF. Questionnaire, yeah, that's the questionnaire, can risk questionnaire. Let's see if there's anything else on the task force that we should know. Okay, so that's how you do the objectives. Let's see the published guidelines. Is there anything for diabetes? Yes, there's one for diabetes. So this is diabetes type 2 2012 Canadian Task Force guidelines, right? So let me open one of the screening guidelines according to Canadian Task Force. So CanRisk is the tool that we have already discussed, why has been selected as a preferred screening test. So yeah, so there's nothing in here that we should read or emphasize on. Let me see if there's anything else that you guys need to cover in this. Yeah, so that's just the same. For low risk you need to screen. You're not supposed to screen. For high risk it's recommended 3 to 5 years. If the patient is like more than 40 with low risk, every 3 year. But if the patient is having high risk, then you need to screen um, annually, or 6 to 12 months. So that's about it. I think we have covered the diabetes guidelines. So we'll see you in the next video. I hope you like this video, and please give it a thumbs up. Thank you, and do subscribe to my channel.